the session, and he has just messaged that he might get a couple of minutes late because he have an urgent patient to take care of. So till the time he joins, we were thinking that we will show you an educational video regarding communication. By the time my colleagues Anub and Rajalakshmi get ready for that, I have a humble request to make to all the participants of this batch as a coordinator. There has been communication that the attendance of this batch is having some technical glitch as reported already. The attendance of some participants are not getting reflected in IECO. We are definitely looking into that, and the same has not been announced that resolved yet. And another request is that please do support us in giving quality support to you, because when we do understand you are very really busy professionals, but when you are trying to connect with us during this peak time when the session is going to start, it may affect the quality of service we provide to you, because we may not be able to get back to you in time. So we request to you that from this 4:30 p.m. Indian Standard Time till the session ends, please do refrain from calling us or messaging us with individual status like attendance or assignments or any personal status, so that we can focus fully on the session coordination and give you quality service. I hope the message is clear. Anu, are we ready with the video? Or
can you wait for another 2 minutes, Priya? We are looking
no?
into.
No worries, no worries. Meanwhile, just let me check. Maybe I too will have yes, I do have. Can I play it over?
Yes, you can.
Let's start our second day of communication. May I invite our faculty, Dr. Biju Raghavan. Over to you, sir.
Thank you, everybody there in India. So we are back for the second session today, and welcome to all the delegates who are joining in online for today's session. Today we are going to do the second part of communication skills training program, and today we will be talking about certain advanced communication areas. Let me share the screen with you. I hope you can see the screen.
Yes, sir.
Can somebody confirm whether
Yes, sir.
it is visible? All right. So my apologies again. My voice still isn't up to mark. So today we are going to do a session on some advanced communication. I call them procedures because just like any medical procedure, which has an indication, which usually has a SOP, standard operating procedure, and an expected outcome. So these three elements of indication, SOP, and expected outcome applies to communication skills of an advanced nature. So what are the three things that we are going to cover today? One is communicating bad news, and we'll talk about the various models that we usually see, and we'll also talk about why it is important to communicate bad news. And from there, we will take a detour to collusion, why it happens, what exactly it is, and how do you deal with it. And from there, we'll come back to communicating bad news, but this time we will talk about how to do it, SOP. And last, we will talk about how to deal with anger. So talking about breaking bad news, I stopped using the word breaking bad news because breaking involves a little bit of it word implies a bit of a violence. So we are not breaking anything. We are just communicating the news the truth, the truthful news. So it is bad because it is difficult to bear sometimes, and naturally those who have to communicate the truth may not be very popular. So truth has never been popular. So even Plato wrote that no one is more hated than he who speaks the truth. Therefore, it is a difficult thing, and perhaps the reason why most of us medical professionals don't really look forward to communicating bad news. And most of the time in our environment, we may tell the family members what we usually don't talk to the patient. So not telling the patient is a non-disclosure model. You are not disclosing to the patient. And we may have many different reasons for doing that. And some of the reasons I put it up in the dialog box over there. And the problem with this model is that what if somebody wants to know? And we understand that every patient has the right to know. So this model, that is non-disclosure model, gets into conflict with the patient's right to know. And people may want to know for various reasons. Now, a totally different model is full disclosure model. In some countries, you are by law required to tell the truth to the patient and only to the patient, nobody else. And with the permission of the patient, you may reveal it to the family, but otherwise, no. So here in this kind of a model, the patient has no choice, but the patient has to hear the truth, the full truth, and nothing but the truth. Now, in this kind of an environment, the societies which practice this model, this gets into conflict with the patient's right not to know. Just like the patient has the right to know, similarly, the patient also has the right not to know. Therefore, these two models has a fallacy, and the fallacy is that we are determining whether the patient should know or not. We are not taking into consideration what does the patient want. Therefore, we are now having a third model. It is called the individualized disclosure model. Basically, what this implies that first we need to figure out whether the patient wants to know or not. And secondly, we need to figure out if the patient wants to know, then how much the patient wants to know. Does he want to hear the full story, the half story, quarter story, 3/4 of the story? We need to figure that out. So that would constitute an individualized disclosure model. We have to figure out whether the person sitting in front of you wants to know it or not. And if no, we don't tell. If yes, we tell. But then we also need to be aware of how much to tell. It should not be less, it should not be more, it should be optimum as to what the patient wants. However, before we get on to, probably I've intrigued your curiosity, but before we get on to how to do it, we should understand few other things. The question is, why should we communicate bad news at all? Many a times, people, if they understand what is going on, they get time to finish a lot of things before they become incapacitated. It could be related to their finances, it could be related to their relationships, it could be telling goodbye, it could be telling the password of the bank account, anything and everything. It also includes giving them a chance to do the things that they would have loved to do, but they have kept away because of day-to-day issues of living. So a bucket list. Or it is an opportunity to catch up with memories. It's time to strengthen the relationships that we have, and also to reach out to people we have lost touch with over a period of time. It's also a time to forgive those who sinned against us, and also to ask for forgiveness whom we may have hurt. All of these things are possible, but that happens only if I were to know that my time is limited? And how would I know? Until and unless you tell me. Therefore, if you were to tell me, initially, of course, I would cry, I may haggle, I may, try to bargain with you that, if can we do this treatment, that treatment, will I get better? Ultimately, if I come to a realization that, this is the truth, then after all the heartaches and crying and anger and things like that, once I calm down, then I'll sit and think, okay, now what should I do? So these kind of things will come up that point of time, but this won't happen until unless somebody tells me to begin with. Another problem is, if I don't know that I have an incurable, progressive, advanced medical condition, my expectation is that I will get better, I'll be back to normal, but that is not going to happen. So basically, there is an expectation reality mismatch. My expectation from my point of view is very normal. My expectation from your point of view is unrealistic. How do I know? Nobody told me it is unrealistic. Therefore, what happens is, despite your best effort in providing care for me, you are never going to reach up to my expectation. As I said, my expectation for me are very normal, reasonable, rational, but from your point of view, it is unrealistic. Then what happens? You will get frustrated, you will get irritated with me because I'm constantly demanding that I get better, better, better. And from my point of view, I realize that you people are not good for anything. I had a lot of faith and trust in you, but now I realize that you are not good enough. So I lose faith in you and whatever you're providing for me. Then I tell my family members that these people are not good enough, take me to another place. My family members may know the reality, but they're forced to take me to a new place because I am demanding it. And they take me to a new place. There my hopes rises. I expect that things will be better. After some time, I realized that place is also not good. I curse the doctors there, I curse the hospital, I curse, and I demand my family takes me to another place. The family takes me to another place. The same thing happens. Eventually, I believe my family does not want me to get better. I start cursing them. I start, thinking that probably I cast aspersions on their intention. I say words that will hurt my family members. I say, you don't want me to live, you want me dead, you're after my property. So all of these things happen because of hospital hopping and doctor shopping. If somebody had told me this is the situation, that you're not going to get better, but we'll make sure that you remain comfortable and we'll provide everything for that. Probably after the initial crying and things like that, I will settle down and I'll come to terms with it and I'll accept my reality. And not only I would not have suffered going from place to place, the physical suffering of going all over the place, the fatigue and discomfort associated with it. Me and my family would have saved a lot of money. Because by this time, going from place to place, my family would have sold off the cow, the jewelry, the utensils, and even the roof over our head. And I will die and my family will be literally on the road. And who is responsible for it? So a lot of poverty in our community happens due to financial burden, the financial toxicity of modern medicine. And somewhere we also need to be responsible for it. And if somebody had just told me the reality, probably somebody could have saved me and my family from hospital hopping and doctor shopping. Another issue is the barriers in relationship that this can bring up. Many times in my personal experience, I have seen that when the family member comes to see me in the OP, proxy visit, the patient is at home, the family member has come to report and to take the next prescription. Often while telling about the issues, they just break down and cry in front of me. It's almost a daily recurrence. It's almost a daily occurrence. When I see patients in the IP, the family members come out of the room by the end of my visit to the patient, and in the corridor away from the room, when they talk about, what is going on, they cry. And they are never able to cry in front of the patient, because in front of the patient they are playing a drama. They put on a mask of normalcy and pretend, that everything is fine. And when their emotions, threatens to overflow, when their eyes turn moist, then they go someplace and cry and then come back. The patient observes the body language of the family members, the body language of the doctors and the nurses. The patient knows there is something terribly wrong. Patient just doesn't know what exactly, but patient understands that things are not going well. The patient's body does not lie to the patient. The patient's body tells the truth to the patient that I am not getting better. But patient also realizes nobody is telling the truth also. So it is like a glass wall. Everybody is, the whole world is on the other side. Is alone on this side, because nobody is opening up to me. And I know that you people are lying, but I just don't know exactly what. I don't know why I'm not getting better. I know I'm not getting better. And I don't have answers. You people seem to know the answers, but I know you will not tell me. Then this thing about relatives from far off places coming to visit, and they're standing at my door with their hand on their chin, with this look of sympathy, and I absolutely hate it. And I am angry at my family members. Why are you allowing these idiots to come into my house? Tell them to get out. But my family members obviously can't tell this to my relatives. They just stand there helpless. I can hear voices coming from the next room, and they are whispering, and I know they are talking about me, but they will not talk to me. And all of this, I hate you people. I hate my family. I am totally upset, and my family is also upset. They're all, and nobody knows what to do. And all of this complication happened. Why? Because we, the healthcare professionals, perhaps did not make an effort to talk about these issues. And why do we even make an effort? It is so uncomfortable to talk about these issues. Plus we have better motives not to talk about it, because a family member themselves come to us and says, doctor, please don't tell this to the patient. Please, please, we beg you, please don't tell this to the patient. The family members themselves voluntarily come to us and say, they come to us in the OP, or they come when we go to see the patient, they buttonhole us in the corridor and say, please don't tell it to the patient, please keep this between us. So the family members themselves come to us to indulge in a conspiracy of silence. That is incentive for us not to talk about it to the patient, because we say, okay, good, I am myself very uncomfortable talking about these things, so now the family also does not want me to talk about this. Great. No, so my problem is taken care of. So this thing about somebody coming to us and saying, please don't tell it to the patient, this phenomena is called collusion. And collusion is nothing but a conspiracy of silence. It can happen both ways. Sometimes the patient who knows about it will try to enter into a conspiracy of silence with us, saying, doctor, please don't tell it to my family. Please don't tell it to my children. Please don't tell it to my wife. The family members indulge in collusion and tell us, please don't tell it to my husband. Don't tell it to my wife. Don't tell it to my father. Don't tell it to my mother. Don't tell it to my child. So it can happen all over. And somewhere we are kind of, we say, if we are not, really comfortable about these things, we say, okay, great. However, we understand that communicating bad news is very important. I've just given you 3 reasons, because it allows people to finish off their life's business. It prevents hospital hopping and doctor shopping. It also, allows strengthening of relationship, real relationship, where there's an opportunity to hug and cry. There's an opportunity to say goodbye. There's an opportunity to say, I love you. There's so much that can happen for real in relationship, only if we are not afraid to talk the truth. And when it comes to collusion, how do we manage it? The reason that we need to understand that people indulge in collusion is because they are trying to protect their loved ones. And they also need our services. So it's a terrifying experience for the family who is coming to us. They need us, but at the same time, they're scared of us. They're scared that we may knowingly or unknowingly, intentionally or inadvertently, may spill the beans, may let the patient know what the truth is, and they're mighty scared of that. And that is why they come over and say, they plead, please don't. And in it, they are trying to, in their own way, trying to protect their loved one. And why? Because they believe that is going to harm. And for each one of us, we have our own belief. It could be a political belief, it could be a religious belief, it could be a belief in the laws of nature, it could be a belief in anything, laws of Newton, whatever. But the point is, we all have beliefs. And for us, our beliefs are real. It may sound silly for another person, but we hold to our beliefs. So if a person believes that telling the truth is harmful to their loved one, then that is the truth for them. Therefore, if you challenge, no, it is the patient's right, it is their right to hear it, there are advantages to hearing it, therefore you should convey, they are already scared, and now you are making them mighty scared. So much so that if they're scared enough, they will take the patient and run away from you, because they would rather protect their patient, their loved one, from harmful news than get the benefit of comfort care or the medical care from your side. Therefore, first remember, now forget about the patient, focus on the family. You have a family which is in a state of anxiety. And in palliative care, we talk about relieving the suffering of patient and family. So now focus on relieving the suffering of the family. Take care of their anxiety by saying, okay, no problem. So basically agree to collude. So when I have a family member who comes in anxious and says, doctor, please don't tell it to the patient, I said, okay, fine, no problem. I also asked, what have you told him or her? And the family member will say something like, oh, I told that patient as XYZ. And I said, okay, fine. So may I also say the same thing? And the family member say, yes. So basically, the family member's anxiety is now palliated. That does not mean the family member start trusting me. No, only the anxiety part is taken care of. The family member may still be worried that I may accidentally say something. Therefore, the next step is to earn the trust of the family. In the SOP, the first thing is to relieve the anxiety of the family by agreeing to collude. The next step is to get the trust of the family. And to earn the trust of the family, employ empathetic, active listening skills that we talked about day before yesterday. Because it's all about, it helps you build up a relationship with people in fast forward. It gives you time, it saves you time, energy, effort, and it gets you the outcome you're looking for. And in this case, it is the trust of the family. So active listening skills will help you earning the trust of the family very fast. Another important thing would be when you practice your knowledge that you gain from symptomatology that you are learning as part of your program, how to take care of pain, breathlessness, nausea, vomiting, delirium, etc., etc. So when you provide physical comfort to the patient and bring a smile on the patient's face, the family member is so relieved, and this also contributes to them trusting you. Just imagine, God forbid, if somebody very close to you has been suffering a lot, and one person comes and takes care of that suffering and brings a smile to your loved one's face, you're naturally going to, be very grateful and trusting that person. So good grasp of symptomatology, how to get somebody physically comfortable, and good grasp of active listening skills will earn you the trust of the family very, very fast. And once they trust you, then they will start listening to you. And that is where you bring in these topics, you gradually reorient them. So this can happen in the first meeting, second meeting, third meeting, whatever, depending on the situation. No two situation will be similar. No two patient family interaction with you will be similar. But I'm just telling you in general, this SOP that you practice, that once you earn the trust, then you bring in these topics, then gradually you will be able to reorient the family to a point where the family member would say, Doctor, I can't tell, but can you help me? So when I reorient the family to that kind of situation, then I offer my expertise. I said, okay, fine, I will talk to the family. So basically, I get the green signal from the family. That is, I manage collusion. Only then proceed to communicating bad news to the patient. I will never proceed communicating bad news to the patient without getting a okay green signal from the family, because frankly I don't want to get into trouble, because ultimately a very sick patient will eventually die, and later on the family can sue me and do all. So therefore it is very important that I proceed with all of this only with the permission of the family. And it is possible that the family may not agree. And if you find that despite your best efforts, the family is not agreeing, do not push beyond a point, because then it will appear as if you have an agenda in this. And then that will create friction in your relationship, and all the good work that you have done so far to build up a relationship, a trusting relationship, all of that will go down the drain. So it is very important that you try, but don't make it your agenda. Don't push beyond a point. Now that brings to the failure part of it, that we may try to reorient the family. We may not be able to, we fail. Please remember, there is no shame in failure. I repeat, there is no shame in failure. The only shame is in not trying. The only shame is in not trying. And the more you try, the better you get at it. Because remember, it is a skill. Just like you take BP, or how you put a cannula, or how you put a central line. So these are the skills which initially you will fail. But as you continue to practice it, you will get it right more and more. But you're never going to get it right 100% of the time. You're never going to get away when you put in a cannula the first time. Your success rate may be 80%, but still 20% of the time, you may need a second try to put in. So what I'm trying to say is that collusion management is a skill. Initially, you will have plenty of failures. The more you practice, your conversion rates will improve, and your ability to reach the patient to communicate bad news will also improve. But be prepared for failures. And there might be situations where the patient says, tell me what is wrong with me, and the family insists, don't tell him. Then you will have to bide time. There are ways of going about it, because it is not that either I tell the truth or I tell the lie. We can say, you can tell the patient, I need more information. I don't have enough information to share with you for the time being. I need to understand a few more things. And you are not lying, because what you're saying essentially is, I have the medical information, but I don't have enough information whether your family will allow me to have this conversation with you. And that is true. You're not lying about that. Basically, you need all this information. You need the medical information as well as the social information and the green signal. So right now you don't have the green signal from the family. You don't know whether you will get it in the future. You don't know, you may not get it in the future. So therefore we can buy time with the patient is by saying that. Meanwhile, you can talk to the family. You see, he is asking me these kind of questions. Now please help me, what should I do? So basically you share the responsibility with the family. You make the life difficult for the family members also, so that they, ultimately come to a point of conversion. So there are ways of it. Obviously we can't do all of that in a session. That is something you learn with mentorship. When you see people who are good at it actually doing it, then you learn how these things are done, right? Okay. So once we have the green signal from the family says, please go ahead and tell my husband, my wife, my father, my mother, or my child. And then you talk to the patient. And how to communicate bad news all over the world? It's a SPIKE protocol. And the SPIKes is an acronym. It stands for what you see on the screen. Setting up the interview, assessing the patient's perception. Yesterday, remember, we talked about finding out the patient's insight. What does the patient know? That is what patient's perception is. Obtaining the patient's invitation, because we need to find out whether the patient sitting in front of you wants to know or not, right? So we need to get this invitation from the patient. The individualized disclosure model, the first tenant, find out if the patient wants to know or not. And if the patient wants to know, has given you the invitation to talk about this, then you share this information. That is, you share the knowledge. The case stands for knowledge. And obviously, when you're sharing this information, don't use medical jargon. Speak in a language which is easily understood by everybody concerned. And obviously, when you are sharing the truth is going to hurt, and there will be emotions. Then you need to deal with those emotions. And later on, once you have dealt with the emotion, easier said than done. Once you have dealt with it, then we can talk about how do you plan for it? What's the strategy? And what's the summary of everything that happened? So this is basically the SPIKes protocol. So I just totally made up one story. So here is the reference letter that has come to you from another center of Mr. Bharat, who is a 60-year-old gentleman, presented 2 months ago with abdominal discomfort and weight loss. He was initially seen by the local GP and then referred to the gastro specialist at City Hospital. And their CT abdomen showed a mass lesion stomach, and OGD biopsy histopathology showed CS stomach. An exploratory lab was done, and it showed multiple peritoneal metastases. So nothing much could be done about it. So it was closed. And this patient is referred to you for symptomatic or supportive care. And now the patient is there in front of you. So this is basically a short referral letter. It gives you all the medical information that you need. Okay? And now, if you an average consultation would go something like this. So you ask the patient, come, Mr. Bharat, have a seat. Tell me, how can I help you? So Mr. Bharat says, I've been having gas since about 2 months. So I went to my local doctor. He gave me some gas tablets. There was no relief. And after about 1 week, I went back to him and he said, okay, let us take an X-ray of your stomach. And after that, he gave me a letter to see the gastro doctor in the city hospital. So I went there and the gastro doctor did a scan and a tube test, and that was horrible. And then after that, he said that a surgery is required. So I didn't have any money at that time. So I said, okay, let me go and find out how I can make money. So I went back to my village. I sold my cow. Then I borrowed some more money, and with all of that, I went back to the hospital, and they gave me a date, and I got admitted. And after that, the surgery was done. And after surgery, they said, okay, now we are giving a letter. And they said, okay, with this letter, I have to come here to see you. So this would be a typical story. However, we need to, find out what does the patient understand. So this kind of a simplistic history taking will not help. And if we employ all the history taking that we talked about in history taking 2.0 that we did day before yesterday, and if we dig deeper, we will find out more information. And I always say information is power, and right information is the right kind of power. Let us try it once again. So, hello, Mr. Bharat, come have a seat. Tell me, what brings you here? How can I help you? Doctor, I had gas since about 2 months. So I went to my local doctor. He gave me some gas tablets and I took it. There was no relief. Then about 1 week later, I went back there and he said, okay, let's take an x-ray of your stomach. And after that, he gave me a letter to see the gastro doctor in the city hospital. Wait. Did your doctor tell you what was there in the x-ray? No, I don't know what was there. Okay. Then why did he send you to the gastro doctor over there? I guess for treatment. Okay, right. Then what happened? So the gastro doctor did a scan and it test, and after that he said a surgery is required. Wait. What was the result in the scan? What did the doctor tell you? The doctor said something I did not understand. So I don't know what was that. Okay. And what was this tube test about? What was that for? I don't know what. I mean, he said that it has to be done. It was a very bad experience. Okay, then what was the result of that? Did they tell you what did they find out? No, I don't know what was that for. And you said that you have to do surgery. So, did they tell you why surgery was? What the reason for surgery? No, they said surgery was required. And then what happened? I did not have any money, so I sold cow and then borrowed some more money. And thereafter, I went back to the hospital and they gave me a date for the surgery. And after the surgery, this letter to come here. So what did they tell you? I mean, what was the surgery about? What did it do? What was the problem that they faced?
Dr. Biju?
We are facing some technical difficulty.
I think he got disconnected.
We'll wait for a moment.
Yeah, Anu, can we just pause the recording at that moment, please?
Yes, ma'am.
Right. So, basically, when we dig for more information, we get more information and the right information. So that is what I was trying to convey. And this gets you the insight. We know where are the blank spots in the patient's understanding, the patient's perception. Next slide. So before you proceed with this, it is very important to do some preparation. And that means updating yourself on the medical condition. This is an elective procedure. Sometimes you may have to do it as an emergency, but by and large, it is an elective procedure. You have to find time for it. You cannot do it in a hurry. And also it will be helpful if you have some comfort measures, some enough chairs, water, tissue, yes, because there might be some emotions along the way. So it is good to have all of this if possible. And of course, practice active listening skills. Next. So there might be patients who may not be forthcoming, who may not be asking you what is wrong with me. And for those kind of patients, it is better that we explore, we kind of poke. And that would include a statement like, Mr. Bharat, you told me you continue to feel tired. Do you wonder why? Do you want to know anything about your disease? So these kind of statements might get you a reaction. This is not for patients who are already asking you, doctor, what is my problem? These are for the silent types who we don't know, we are not very sure. So we just kind of do a little bit of exploration. Next. And what you may usually get a next, you may usually get a response, yes, I do want to know about my disease. Now, just because somebody voluntarily saying, doctor, what is my disease, or somebody says, yes, I want to know, based on your poking, your exploration, that does not mean that you can straight away start telling the story. No, you have to ascertain, you have to be very, very sure before you do that. So for that, you have to give a warning shot next. And the warning shot does two things. One, it immediately creates a very, very serious environment. Till now, the discussion was in a normal, like any normal conversation between patient and doctor. But the moment you give a warning shot, suddenly the atmospheric changes. And the second important thing is, when you say something like, if it is something serious, do you still want to know? When you give a warning shot like that, then the patient has two choices, either to go ahead with it or not. And next slide. And if you see a patient with a body language like this, it is not making eye contact, not looking into your face, and or along with it may also be saying something which kind of changes the topic. For example, I just give you the medicines, I'll come after 1 week, or if is saying, you tell it to my children, or if somebody says, no, I don't want to know any of this or all of this, or especially the body language, then that means here is a person who is not prepared to hear the truth. Do not proceed when you see something like that. Next slide. And in case you see somebody who looks into your eyes and says, yes, I want to know, after the warning shot, then it is 100% clear that here is a person who really wants to know, even if it is a really bad news. So just before you just say, do you wonder what is going on? Are you interested to know about what is going on? And somebody says yes, then you give a warning shot. Can we go back to the warning shot? Yeah. Next slide. Yeah. So this is very important. How you structure the warning shot is very important. For example, in Malayalam, I would say, കാര്യങ്ങൾ serious ആണെങ്കിലും അറിയണമെന്നുണ്ടോ. In Hindi, I might say, अगर बात serious है, क्या फिर भी आप जानना चाहेंगे? And in English, obviously, I'll say exactly what it is written. So there are two parts to it. One, you are conveying it might be something serious. And the second part is a question, would you still want to know? So that is how it is constructed. So it conveys that there is something really serious, and we are giving a choice. Do you still want to know? So that is the important part of it. And if you're speaking any other language apart from Malayalam, Hindi or English, then, to your patient, of course, then you need to practice how you are going to convey, because this is something that you can't fumble. This is something that you can't make a mess of. This has to come out very clean. So it's a good thing to practice giving a warning shot so that when you get an opportunity, you're able to do it well. Next slide. Next. Okay. So once you have a patient, next slide, who says, yes, I want to know, then how do you proceed? You do this by telling a story of the patient to the patient from the beginning. And while you're telling the story, you fill in the blanks. And while you're filling in the blanks, you escalate the information as you go along. And while you're telling the story, filling in the blanks and escalating information, you watch the patient's body language, especially eye contact. If there is loss of eye contact, you pause the story then and there. There might be one or two reasons for that. One, the patient got a new information, totally unexpected information. And then the patient needs some time to digest this new information. That could be a place where the eye contact is gone. You don't know, but you pause the story. And later, after some time, when the patient looks back at you again, then you can continue the story. If not, let's say the pause is very long and you don't know whether the patient is contemplating, thinking about it, or if the patient had enough. We don't know. So then you can ask something, you can break this long pause by asking, whether the patient wants to know more or what is he or she thinking about. Do they want to ask something? And if that situation, they again make eye contact and then ask something or ask a question, then you can answer that and then you can proceed with the story. But if they are not making any of these things, no, not really making eye contact or nothing like that, then we'll have to assume that they had enough and they don't want more information. Then do not proceed. This way, we fulfill the second criteria of individualized disclosure model. That is, we give information according to what the patient wants. That particular patient wants, not less, not more, just the optimum. And when you measure it according to the body language of the patient, that would be optimum. And this is how we ultimately do it. I'll just give a small demo of it. Next slide. So we have given the warning shot and Mr. Bharat has looked into your eyes and said, yes, I want to. So now we'll do a small role play here. So Mr. Bharat, you have been suffering from gas since past 2 months and you went to your local doctor and you said that he gave you some gas medicines and you took it for about 1 week and there was no relief. And thereafter, when you went back, your local doctor advised you to get an X-ray done. Next. In that X-ray, they found something like a shadow. And to know more about the shadow, he referred you to the city hospital. Next slide. Oh, I didn't know that. Next slide. And in the city hospital, they did a scan and the scan showed something like a tumor. And to know what this tumor was, they did the tube test. It's called endoscopy. Next slide. So now, person is not saying anything, but the eye contact is still there. So I just want you to just go back a few slides. Can we go back to the slide where we talk about the X-ray? Yes, over here. So see how it is constructed. The first sentence, it is something like a shadow. Nadilu pole endo kandu, parchai jaisa kuch dikha. And in the next sentence, this shadow, something like a shadow, is escalated to shadow. It is no longer something like a shadow. It is now shadow. X-ray showed something like a shadow. And to know more about the shadow, he referred you to city hospital. Nedilu pole endo kandu. Ee nedilu endaanennu ariyan vendi city hospital vittu. Parchai jaisa kuch dikha. ये परछाई क्या है जानने के लिए आपको सिटी हॉस्पिटल भेजा. Next slide. Next slide. City hospital, they found that the scan showed something like a tumor. So something like a shadow becomes a shadow. Shadow becomes something like a tumor. and to know what this tumor was. So something like a tumor becomes a tumor. So you are filling in the blanks and incrementally escalating the information. നെടില് പോലെ എന്തോ കണ്ടു, ആ നെടിൽ എന്താണെന്ന് അറിയാൻ വേണ്ടി അവിടെ ചെയ്തു. സ്കാൻ ചെയ്തപ്പോൾ മുഴ പോലെ എന്തോ കണ്ടു. मुझे എന്താണെന്ന് അറിയാൻ വേണ്ടിയാണ് ट्यूब टेस्ट. परछाई जैसा कुछ दिखा, परछाई क्या है जानने के लिए वो आपको भेजा वहां पे स्कैन में. गांठ जैसा कुछ दिखा, ये गांठ क्या है जानने के लिए आपको बाकी टेस्ट करवाए. So this way you gradually fill in the blanks and escalate the information. Next slide. So as I said earlier, there is eye contact, you can continue. Next slide. And the tube test was done to see if your tumor was something like a cancer. Next slide. Cancer? You mean I have cancer? So basically something like a shadow becomes a shadow. Shadow becomes something like a tumor. Something like a tumor becomes a tumor, and tumor becomes something like a cancer. So this is how we gradually, at some point of time, the patient may say something like that. And next, and at this point of time, you can just, shake your head in agreement, or may add something like, I'm sorry, yes. And it has to be, obviously, it has to be not exactly how we are dealing with in the classroom. It has to be a little bit more of your body language, your tone of your voice, the expression on your face, everything comes into play here. Next. And now there is no eye contact. And so, as is mentioned earlier, you just have to pause. Next. So you're pausing. Next. Still no eye contact. We don't know how long we should wait. So we don't know. We think we have waited for a reasonable period of time. Actually, it is only 30 seconds. And so maybe I'll say after a reasonable period of time, I'll say something like, next slide. Mr. Bharat, what are you thinking? Enda aloikkunnu? Kya soch rahe hain? Or Mr. Bharat, do you want to know more? Mr. Bharat, കൂടുതൽ അറിയാം, ഇനി അറിയണമെന്നുണ്ടോ? Mr. Bharat, क्या आप थोड़ा और जानना चाहेंगे? So something like that. And then next slide. So the Mr. Bharat finally makes contact and eye contact and says, they had operated and removed my cancer, didn't they, doctor? Next slide. I'm sorry, Mr. Bharat, when they opened up your tummy, they found that the cancer had spread all over. They could not remove it. They just had to sew it back. Next. They lied to me. And now the emotions are coming. The emotion can be in the form of tears, heartbroken tears, or it could be, next slide, in the form of anger also. They lied to me. They did not tell me anything. So it could be either way, they are emotions, whether it is tears or the fire of anger. All of them are emotions. And how do you deal with it? Next slide. You deal by not doing anything, but by being there. And being there 100%. You don't check into your mobile for Facebook and WhatsApp. You don't look at your watch. You don't look at the EMR or computer. You don't look at the case sheet. You don't look at any of it. 100% you are focusing on the patient. That does not mean you stare at the patient's face. You focus on the patient. You don't have to look at the patients. You can also lower your eyes, but be there 100%. And don't do anything. Don't say anything. Don't give stupid cliches like, don't worry, we are there with you. Don't worry, everything will be all right. None of those things are going to work. Just be with the patient. Now, most of the time we healthcare professionals are taught to do something. We are not taught not to do something. The only parallel that I can think of is during surgery when an unexpected bleeder comes. An unexpected bleeder comes in and you can't tie it, neither can you cauterize it. Then what would the surgeon do? The surgeon will take a pad and put pressure on that bleeding area and wait and do nothing. Just wait. Everything comes to a stop. It could be a kind of a parallel analogy in our medical profession. So this is what we have to do. Don't do anything, don't say anything, just be with the patient. If you're feeling very confident, you can touch the patient, but don't touch for too long. It again becomes uncomfortable. Just an optimum touch and then take your hands off. You don't have to do it. Do it only if it seems right. Next slide. Once the emotions, it might seem the 2 minutes of this crying might seem like 2 years sitting there and not doing anything, but that is the skill that we have to develop. But once all this emotion is ventilated, people in still high state of emotion may ask a few questions. Doctor, how am I going to die? How much time do I have? Or or I'm so afraid, or things like that. People say many things when they are emotional, or even when they are not emotional. And this is especially very important, that we have to not take it at face value. We don't know why people are saying what they are saying. So therefore, never assume. Next slide. Always ask, why did you say that? Next slide. And the reason could be because somebody needs to plan something. And in that situation, you have given answer that is most appropriate for that situation. Another, next slide. Another situation that I will show is the same question. How much time do I have, doctor? And your response is the same. Next slide. Why did you ask that? And the response, next slide, could be totally different. Why did God do this to me? So earlier there was a patient who asked the same question, and the reason was because the person had plans to take care of. And the same question, another person asked the same question, and the person still needed some ventilation. So you have the same thing that people say, the 10 people will say the same thing for 10 different reasons. That is why we are individuals. And therefore, it is important that we do not assume why people are saying. The simple thing to do is ask, and then you will get the correct information about. They will tell you why they said what they said. Otherwise, we can make a mess of things, especially when we are talking about highly complex situations of incurable progressive medical conditions, and we are communicating the truth, and there are high emotions associated with it. We cannot afford to go wrong by making assumptions. Next slide. So once we have given them the information which is optimum to them, and once the emotions have been taken care of, and once the questions have been answered as to what is possible, what is not possible, where to go for that, what are the possible expenditures of going ahead with whatever the options we have discussed, where these possibilities, where these facilities are available, what are the contact numbers, etc., etc., etc. Always remember that this is just like we spoke last time. Everything is a participatory decision making. We tell them what is going on. We tell them what the options are. You guide them what is the best option according to you. Then based on their reality, their constraints, financial, social constraints, or whatever constraints, then you arrive at a decision which is most practical. And as always, you never leave people without hope. Only thing is you never give false hope. You always give realistic, achievable hope. And that is what you leave them with in the end. Next slide. So once you have conveyed this, sometimes it is possible that in the ICU or ER or the COVID ward, for example, sometimes you don't have enough time to do it as an elective procedure. Sometimes you have to do it fast. So a small example of how we do it. Next slide. So totally different. Are you the son of Mr. Bharat, the hospital number so and so, who was admitted yesterday evening? So basically, make sure that this is the right person. So here you are communicating bad news to the family member because Mr. Bharat has collapsed inside. Next, next. Yes, doctor. How is he now? Next. Despite all the efforts, he is deteriorating. I am afraid he's not going to make it. So keep it short, keep it simple, keep it clear. Next. But he was not this sick when he was admitted. He came walking in, things like that. Next. He has been rapidly going down. I think the virus is really hard on him. I'm sorry, despite all the efforts you have made for him, he's sinking. Now, this is something that I have put it in red. Despite all the efforts you people have been making. Most of the time, what happens is we end up saying, despite all the things that we did, or we always hear this, even in movies, we hear if the patient had reached 2 minutes earlier. Now, saying these kind of things is always counterproductive because I'll tell the second thing that I just said. If the patient was brought in little earlier, maybe we could have saved him. We don't know what is the circumstances in which the patient was brought in. Maybe the patient was taken to some nearby clinic or hospital. And maybe by saying this, we are going to make life difficult for that clinic or our colleagues in the other hospital. Or if they just brought from home directly to you and you're saying, if you're just brought a little earlier, we could have saved. Then I look at the amount of guilt the family members are going to go through. So we are just put that over there. And also when we say we did everything possible for him. So you did everything was possible. So was that good enough? Would perhaps be the thought in the minds of the family members. Would it have been better if we had taken him to some other place where somebody might have been able to do better than what these people have done? So that is again counterproductive for us. So instead of saying all of that, usually what I found more helpful is that when even in an emergency or even in electively, when we are talking to the family members, they are distraught that their loved one is deteriorating. And remember, each one of us is egocentric. We are very, very vulnerable to thoughts that whether we are doing it right, what would people think of us? Like what would the community think of us? Whether anybody will point fingers at me, whether I did not do enough. So as a doctor, as a person in authority, when you tell the family members, you people have done the best possible for him. You have taken him to all the good places. You have made efforts to give him the best possible treatment. Despite that, he is not doing well. Now, everything humanly possible you have done. A lot of high temperature comes down. It's a cooling effect. People just calm down when they hear things like that. So that is a trick that I want to share with you. Give them full credit of having done everything. Don't say, oh, we did everything. You tell them that despite the best efforts from your side, you try to bring it on time, you try to do all of that, but unfortunately, he's not working. Things are not working. So always give this sense of assurance to the family members that they did everything possible. They don't have to go on a guilt trip for how the things turned out. And this is kind of protective for us also, because they kind of calm down and unlikely to turn against us because they are calmed down now. Next slide. What should we do now? Next. Inform everybody in the family, and as soon as that happens, I will inform you. Next slide. And also, if it is okay with you and your family, may I pray for him on your behalf? So these are things that conveys that, despite the limitation of medical sciences, we as a human being, we are still there thinking for you, trying to provide some comfort to you, either physically, emotionally, psychologically, or spiritually. And people understand and appreciate these efforts that we put in. And majority of the people in our country are, have belief system. They may believe in different kinds of gods and divinity, but most of people have divinity. Very few percentage of people are atheist or agnostics. But so if you say something like, uh, you know uh, with your permission, I would like to say a few prayers for him. That is again going to be much appreciated. It is also a protective cover that you're also creating for yourself, because it gives clarity to the family that things are not going well, but it also gives them this feeling that here is this doctor who really cares for my loved one. And even though my loved one is dying, this doctor is trying to, do that much. If nothing else, at least the doctor is trying to pray for my father. So all of these things are very, very important, and these are the very, very important things, though they seem small, which also protects us in an emergency when we have to fast track communicating bad news. Next slide. And apart from that, it will be good to have some skills on managing anger in the clinical environment. So now we are coming to the last topic, which is managing anger. And please remember, we are not police walas, or we are not people trained in martial arts or army, or we don't know. Even if you give a lathi to a doctor, he or she wouldn't know how to break somebody's head with it. Even if you give a gun to a doctor, he or she will find it very difficult to fire at a human being, because we are trained to be doctors. We are trained to use our stethoscope and our brains rather than our brawn. And therefore, uh, we are not good in law and order management. And what is a law and order management issue in the healthcare system? If there is a big mob which is violent, then you are not trained to deal with that. The best option for you is run away from that place as fast as your legs can carry you. Another situation I can think of is if there are one or more than one people under the influence of alcohol or substance, then you can't argue with them. They are not open to reason, and if they are indulging in violence, the best thing is to stay away from that situation. And hopefully people are trained in law and order management will hopefully come and deal with it. At least protect yourself, because you keep yourself safe so that you can keep continuing the good work you are doing. So basically, what are we talking about? We are talking about managing anger in our day-to-day clinical situation. How we can try to douse the fire and prevent it from becoming a law and order situation. Next slide. So basically, what is anger? It is an emotion, just like crying. It's a negative emotion. The difference is it consumes a lot of energy. And to get angry and to stay angry requires a lot of fuel to continue this anger. And there are two varieties of fuel. One fuel is if you argue with an angry person, or if you give excuses, or even if you are trying to apologize to a very, very angry person. All of these things can make an angry person more angry or sustained anger. So this category is called confrontation. So any form of confrontation will escalate the anger or sustain the anger. The second category of fuel is being indifferent to the angry person. You may be feeling very scared and you may not make eye contact, or you may turn your back towards this angry person. All of these things will make the angry person more angry. or if you're trying to say something and you're stuttering and muttering and all of that, then that also will make the angry person very more angry, and it will at least sustain the anger or escalate the anger. So any kind of confrontation or any kind of indifference, both will sustain and escalate the anger. So basically, my analogy is ascites. If you punch the abdomen full of ascites, that does not provide a solution. If you ignore the abdomen full of ascites, that also does not find a solution. So what do? We put in a needle and allow the fluid to drain out in a controlled manner. That is exactly what anger management is. It is exactly similar to that. Only thing is, we have to figure out what is the needle and what is the tube. What are the skills to allow this emotion to come out in a controlled manner, because it is already little out of control. Next slide. So what is the how do you diagnose that somebody is angry? You have the usual symptoms. There's a bulging of the eye. There is, the face is flushed. There is a distinct angry look on the face. Then the volume would be very high, and the language that is coming out would be full of expletives. They may be questioning your genetic materials, and all of those things will be there. Along with it, you will not see somebody lounging on a sofa and being angry, because there will be so much of adrenaline that person cannot sit down. The person would be pacing around being angry, or at least standing at some place and being angry. So angry. So these are the symptoms with which you diagnose anger. Next slide. So once you have figured out that you have seen an angry person, then what do? Here, the body language is the most important thing. You don't say anything, you don't do anything confrontational, you don't ignore this person. Basically, what you do, the moment you see that somebody is there who is angry, you stand up, because that person is in a standing up position. And when you stand up, you are equalizing the eye contact. And remember, last time during body language, I said, when you equalize eye contact, you create satisfaction, because you're bringing in equality. You're showing, your body language is showing, I see you as my equal. I don't see myself as superior. I don't see you as inferior. Because remember, in the healthcare system, the patient and family is hierarchically always below any healthcare provider, because we are the service provider, they are the consumers. Unlike other areas, here they are dependent for their lives and well-being on the healthcare provider. So the equation is very different than when you go to a hotel for food, or to a cinema to watch a movie, or to a resort. There you are the lord, as a consumer you are the lord and master. Here, as a consumer, you are the underdog. The service provider is the lord and master. So when you equalize eye contact, you are giving satisfaction, which we talked about last time. Then when you stand with a little bit of kyphosis. That shows I am respectful towards you. No exaggerated kyphosis, just a slight kyphosis. And also keep your hands where they can see it comfortably, because psychologically we are wired to, because when you're angry, you're also scared, because that is what happens in confrontation. There can be violence, and the best form of violence is a weapon in the hand. So all over the world, show of hand, like salute or namaste, or showing the hands in blessing, these are all various ways of conveying that I don't have a weapon, I don't intend to harm you, I come in peace, I come in benevolence. So showing your hand, or at least keeping your hands where the angry person can see them, that also has a calming effect. Your body is conveying all of this. So this is how your body should be. Next. Now let's focus on the face. You make eye contact. So when you make eye contact, you are showing I'm not scared of you. I'm a confident person. So again, it is difficult to stay angry or escalate anger with a confident person. And here, obviously, you will not smile, because a smile can be seen as confrontation, because it will be seen as a hierarchically superior in an angry situation. So in anger situation, never smile. Just make eye contact, keep a serious face, because you are conveying that I am taking you seriously. And then keep nodding your head. When I talked about nodding the head earlier, it was in the context of our history taking. You are encouraging the person to give you more information. So here you are encouraging the person to spill out all the anger, all the emotion inside him or her. So going back the previous slide. So your body language, you stand, showing equality, slight kyphosis while you stand, showing respect, hands in front, showing you are not a threat. You don't intend to harm. Next, your eye contact, showing you are confident. I'm not scared of you, but I'll take you seriously, and I'm taking you seriously, and I'll keep nodding my head because I want you to continue. So it is like a dil mange more. You want this person to continue spilling. So with this, you're neither confronting nor ignoring this person. Next slide. And what happens gradually as the person ventilates the emotion, as the person continues to ventilate the emotion, the person becomes calmer and calmer. The face, the bulging of eyes comes, the eyes goes back into its socket, the flushing of the face comes down, the gnashing of the teeth comes down, the volume comes down. He or she is no longer discussing your genetic material. So all of those things are now coming down. And once from high flaming anger, it comes to simmering anger, then you can ask this person to can we sit down somewhere. Next slide. So you say something like I want to know more about this, can we sit down somewhere and talk. Basically you're conveying that I know, yeah, my I want more, my dil mange more. Basically that is what you're conveying. Now why it is important, because right now this big anger situation is happening in the public space. It may be happening in the waiting area, or outside your OP, or outside the ICU, or outside the ER. All of these are public areas, and everybody who comes into the hospital area are there because they or their loved one is sick or injured. So everybody is stressed. And when somebody is getting very angry, remember, anger is an emotion, and emotion is contagious. And since everybody is stressed around in that area, everything stops. Everybody is looking at this angry person and all this anger, and they're watching what is going on. And it is very easy that this anger will spread, and other people will also start getting angry, because it is like Tinder, because people are already willing to get inflamed, because they're already stressed out for various reasons. So it is very important to bring this anger down and get this person away from the public space into a private room. That is why once you have used your body language and brought down the flame, then at this point of time, you tell this person, sir, I would like to know more about this. Can we sit down somewhere and talk? And then you take this person to a private place. And then immediately, as the moment this angry person is removed from the public space goes back to normal. Everybody then walks around, going about wherever they were going. There's nothing more to see. The show is over. Now in the private space, next slide. In the private space, you continue the same thing. Only difference is now both of you are sitting down. While you're sitting down, you maintain eye contact. You also lean forward, little kyphosis, but now you're sitting and maintaining the slight kyphosis. And you can keep, if there is a table, you can keep your hands on the table so that the hands are still visible. If there is no table, you can keep your hands in your lap because it will be visible to the person sitting in front of you. And let this person talk. You keep nodding your head. And again, no smile on your face. Keep it serious. And this way, you allow this person to ventilate till he is empty. And usually my experience is that whenever something like this happens, once they're empty, then they start crying. And they cry because all the stress has been drained out. And then they profusely apologize for all the trouble they created. And then I just touched them on the shoulder and said, no problem. Please, we'll try to do our best for you. So that's, the way we deal with anger. Next. Now, once we have taken care of the anger part, now the crisis is over, but now we need to end it well. And remember, if there was genuinely a merit in that person getting angry, do offer an apology. However, if there was, not much of a merit, then you don't have to offer an apology. Never give a false apology. Never give an apology for the heck of it. Give an apology only if it is really merited. That apology has to be genuine. It should come from your heart, because then the person in front of you can feel it. Because even we can say something without really meaning it, and the person can understand. It gives a bad taste. Maybe it can make the person little upset or little angry that you just said something. So it is very important that apologize from your heart if it is merited. Otherwise, don't apologize. I'll give you some examples of how we can finish it. Next slide. Thank you for bringing this to our notice. We are very sorry you had to experience this. So here is ending it by thanking that person, because basically we are just conveying that, okay, we got some information from you, very, very relevant information. Thank you for that. And we are very sorry that you had to go through this. Next. Another option is without an apology. Thank you for bringing this to our notice. This is what we will be doing. So we'll do this, so that nobody else has to go through this kind of an experience. So this is another example of how we can end it well, with or without an apology. Next slide. So that would be the last slide. So for today's session. So please understand, collusion is basically listening to the family. And the first and most important part of collusion management is to agree to collude. Second part is to earn the trust, and third part is to reorient the family. Of all the three procedures we talked about, the most difficult to master is collusion. You'll never master it, but the most difficult to do is collusion management. When it comes to communicating the truth, please remember, your role is only that of a facilitator of information. You don't have an agenda to give information or to withhold information. You don't have an agenda to give full information, half information. You just facilitate information. The patient will decide whether they want to know it or not. The patient will decide if they want, how much they want, and you serve accordingly. Remember, whether it is crying or anger, both are emotion, and allowing of ventilation is not a waste of time, it is therapy. And if you are lucky to be a psychologist, you can charge hefty fees for that, but otherwise you have to do it for free, unfortunately. Anger management is comparatively the easier of the three skills that we talked about, and it is basically non-confrontational active ventilation of emotion, basically like ascites tapping. Once you know how to do it, you can do it fairly easily. So I'll stop here. I'm acutely aware that I've eaten up a lot of time. So I'll hand over the session baton back to Pallium India team.
Thank you, Biju sir. So the session was so wonderful, we even forgot to look at the watch. So considering the time constraints, so we will limit the session for question and answer solely. And so we are canceling today's case presentation. So we can go for the question and answer session. If anyone have any doubts or queries, you can raise it. Biju sir, we have one query. Like, should we have to get consent form explaining patient's condition before admission from the relatives? Dr. Kamala has raised a query.
Can you repeat the query?
Should we have to get a consent form explaining the patient's condition before admission?
You're talking about explaining it to the family member.
Yes, sir. That before admitting a patient, should we get an informed consent letter from the caregivers
Consent letter about what?
about the patient's condition?
About the patient's health conditions, sir, from the relatives.
I'm not aware of any consent of that. Usually the consent is for either for admission or admission to ICU or for any procedure or DNR consent. I'm not aware of any consent regarding conveying the medical condition of the patient. That is something that we everybody is doing as a routine to the family. We tell the family members what is the diagnosis and what is the prognostication for a patient, what are the possible remedial measures and what is not possible. These are things that we are always conveying. I'm sorry, I don't, if you would explain what exactly you mean or what is the thought process behind your query.
Suppose if the patient is seriously ill,
Yes.
and if the relatives, suppose if they create problems after they know the real condition of the patient. The patient is with a terminally ill patient.
Yes, yes.
Suppose if the relatives create any problem after admission, so should we get a prior consent form that the patient is ill and anyway is going to face this problem? Yes.
Getting a signature on a consent form on a piece of paper, it's not going to protect us from anything.
Yes.
Because if the patient's family members decide to get violent, you showing them that their consent letter is not going to stop them. If they decide to take you to court, you presenting this consent letter is not worth the value of the piece of paper. It will not defend you in the court because the prosecution lawyer will say this consent is in English and this, these people don't know, understand. So that even if it is in the local language, they will say the doctor did not explain, they did not understand, or they were too stressed to understand. Either way, you are going to get the wrong end of the stick. So getting consent is not going to protect you. Yes. What is going to protect you is, having this communication, because at the time of admission, you yourself may not know what exactly is the diagnosis. You may have differential diagnosis of what possibly are we dealing with. That you can convey truthfully. You can say, see, this is the problem that you have come up with. These are the possibilities that I can think of. We will be evaluating, we don't know. But meanwhile, he or she seems to be very sick. The BP is going down, this is going down, etc., etc. If we are not aware of the diagnosis. However, if you are aware of the diagnosis and let us say it is a potentially curable medical condition or potentially an injury which we can get the person out of it, and the person is critically ill, then we'll convey to the family, see the person's BP is going down and person is deteriorating. There's a real possibility of this person dying. But however, if we put him into ICU and try hard enough, maybe it will give us enough time to cure the medical condition or make sure or get over the injuries, get the surgery done, and that kind of thing. There's a possibility that if God is also a little kind of, and if we also put in a little bit of effort, we may get him or her back. The third situation is that we know that this person has an incurable, progressive, advanced medical condition, and the person is terminally. Then in that situation, when the person is brought into the ER, and if we have somebody over here, to convey this, and we can tell them that this is the situation, and what do you want, how do you want to proceed with it. And in my practice, I do this almost on a daily basis. Basically, I don't know whether we have enough time. Basically, for a terminal patient's family members, I when I sit with them, I convey to them that see, uh, if we put this person to critical care, the amount of suffering we are going to inflict on this person is going to be enormous, and we are in any case we are not going to be able to save this person, because the disease is incurable, it is progressive, it is advanced, and the only thing that will come out of it is that we'll end up torturing this person, and that is something you should not do even to your worst enemies. Forget about your loved ones. It is neither ethical, it is neither moral, and from a medical point of view, it is not even evidence-based medical practice. So I think we should do everything to keep him or her comfortable. We should provide oxygen, we'll provide drips, we'll provide antibiotics for the infection, we will provide pain medicines, we'll provide medicines for breathlessness, we'll do all of that. But I think you should protect him or her from being pushed into the ICU, into critical care. But that cannot happen if we agree only verbally. It is something that we need to put it in paper. And what are your thoughts on that? And sometimes they will say, yeah, I also agree, or they say, let me ask the others in the family. Okay, go ahead. Meanwhile, we'll try whatever possible we can. And so all of these things are something that we do on a daily basis. It is ideal if we talk about this as a disease treating consultant little earlier, before you preempt this kind of a discussion in the ER, because it is unfair on the ER physician to have to do this kind of discussion, because in the ER people come with high emotions, and sometimes this kind of counseling may not be possible in the ER, either because the ER physician is not trained in this kind of communication skills, or ER is an unpredictable place. There can be a sudden rush of cases, and the person may not have time to convey this. Therefore, as a disease treating consultant, whether you're an oncologist or a pulmonologist or a neurologist or any specialty, cardiologist, nephrologist, gastroenterologist, doesn't matter. If you sit with your patient's family and convey that this patient that your loved one has incurable, progressive, advanced medical condition, it is a good thing to think about these kind of things. I could have taken a session on end of life care counseling, maybe some other time, but all of these things are possible. We do it on a daily basis, sometimes multiple times in a day, and we always have a good conversion rate, in the sense that family members agree not to subject their terminally ill loved one to critical care. Just a matter of explaining to them the difference. I hope you got at least some part of your answers to the question.
Yes, sir. Thank you, sir. Thank you, sir.
Thank you, sir. Dr. Veena has raised her hand previously. Dr. Veena, you had something to ask?
Yes, sir. I just wanted to know, once the patient relatives have consented to the doctor can break the bad news to the patient, do we need to keep them with the patient and counsel the patient, or without the patient party also we can break the bad news?
How does it matter? Keep it real, keep it simple. When we go to the patient, or when the patient is brought to us, in our culture, it's always the family is around, right?
Yes,
so the important question is family gives consent for it. And add one more thing. I also tell the family members when they say, okay, doctor, we can't say, you please help us with it. I also tell them that, see, if I find that the patient is not interested to hear, or seems reluctant to hear, I will not push this onto him or her. I'll make sure that only if the person also wants to know, only then I will convey. I tell this to the family before proceeding to the patient. And this conversation may be happening at two different time scale, or and maybe a gap of day or two. So when I go to the IP, the patient, and with the family there, it is not that, like, we are not dressed for a certain procedure. Just going there with this, normal, how are you, how are things, and that normal flow. And then you're sitting there and we just casually poke in. So what do you think is happening? You have thoughts on it. Yeah, I'm feeling better now, but I'm not feeling, I'm not just back to it, and I'm still feeling tired. So yeah. Do you wonder why? Do you have any idea what's going on? No, no, well, doctor, what is wrong with me? So um, you really want to know if it is something serious. So it you develop it organically. It is not like structured. You learn it structuredly in the classroom because you need to understand the structure of it. But it's something like that. When as MBBS students, we learned how to take history taking. We were given a structure, presenting complaint, history of presenting complaint, past history, family history. But we may make mistakes like the coconut. In down south we have a lot of coconut trees, so coconut tree fell on the head, so that is the presenting history. Is there any past history of coconut falling on her head? Is there a family history of coconut falling on her head? So we use our common sense, and we take history as a flow. The same thing, in classroom we learn it in a structured way. In real life, family should be there. If the family is gone out to have coffee and you're here, or only one person is there, you have gone for rounds, it is not necessary I will come back till the family is here. Nothing like it. You just do it organically.
Yes, thank you, sir.
I think my suggestion would be to ask the patient himself, like whether would you like someone, your loved one, to be with you when you want to talk.
Yeah.
But we have not told the patient we are going to chat about
Yes,
something. That's what I'm saying. We are not, we are thinking in structures.
Structure.
In real life, it is not structured.
We will have to find a way to put in that question in between the structure.
And while I'm doing this offline workshops, this thing comes up, and there's a problem with that, because somewhere by asking whether you need a family member with you, you're also conveying that I think you're weak. I think you're not strong enough. People resist that kind of usage of that phrases, because usage conveys something, even though you may not mean it that way. You mean it with all good intention, and the person may not show it also, and the person may not even realize it, but somewhere it gives a sense of not being recognized as a person, not being recognized as person who can handle things, who is strong enough. So those kind of things, the subtle things can play in the psyche. So better, why demean somebody by asking, do you want somebody with you? It's not a child, right? And if it's a child, there's obviously there will be somebody around. Point is, keep it simple, take it organic. Work, just flow like a water. You assume the shape the situation gives you. And that would be the simple way of going about it.
Thank you, sir.
Classroom, you can't do it. Classroom, you have to finish topics and you structure it. That is not how you take history or go about any of this is in real life. And real life will be much more complicated also.
Thank you, sir. Dr. Nirali has raised her hand. Dr. Nirali.
Hello, sir. Thank you so much for the wonderful session. My question is that we know that we cannot make the conversation about us, but during the conversation about decision making or communicating the diagnosis or helping the family or the patient to reach a conclusion, can we share our own personal stories, or is that unethical? Where do we draw the line? of being more relatable?
Well, absolutely, absolutely. If it helps to share your own personal stories, great. I mean, it shows the patient and family that you're a human being also behind your stat. Yeah, absolutely. Absolutely. I often do. I often do. I share my personal experiences, how I navigated in the last days of my father, how I navigated the last days of my mother, how me and my sister, navigated all of this together as siblings together. And all of these things is absolutely, why not? It makes you look human. You are a human, right? We all are human beings.
It's Dr. Chandramukhi had something. I think she tried to unmute.
I guess that question has already been answered just some time back.
Thank you, Dr. Sanghi. So Dr. Meera Jain asked, in collision, how long should the doctor wait till the family gives the go-ahead to explain the diagnosis to the patient?
Oh, there is no clear line on the sand. How long? You just continue maintaining your relationship with the family. That's what I'm saying. That collusion is a very, very tricky area. And you cannot answer questions like these are the things that you show how it is done, and where you back off. This is where actually mentorship really matters, where you take some kind of a training under people who are practicing these kind of skills. To put into words, I will try, the best I can do is that when how I do it is basically when I'm having this conversation with the family members, that is away from the patient, because we are colluding. So we can't have this open conversation with the patient in the presence. So when we are having this conversation, I talk to my patient's family members and I say, okay, for example, this is just an example, pain is under control, but obviously he's not getting better, he's becoming weaker by the day. And you heard him say that, why am I not getting better? I wonder what will we do? And if you cut it into sections, I am building up an agreement that comfortable, that is one thing we achieved, but as expected, as the disease is progressing, health is deteriorating. We are in agreement with that, right? So that part is factual. The second part is the problem. The problem is the patient does not understand it. And the patient is saying, why am I not getting better? We both understand it, but the loved one is not understanding. So now I'm creating a problem state. Now, I don't know what the solution is. Frankly, I really don't know, because until and unless I have the family in agreement, there is no solution. And I don't know whether the family member will ever be in agreement. So now I have created the problem statement. Now I am putting this problem statement up in the air for my partner, that is the family. That is, now we are partners to look at this problem in the air and wondering what are we going to do about it. I did not say, I'll rephrase the statement. I did not say the pain is better, the patient health is deteriorating, and you noticed he's saying that, why am I not getting better? Tell me, what will you tell him? What will you do? I did not say, what will you do? I did not say, what will I do? I said, what will we do? So basically, when I use statements like, what will we do? I am emphasizing that I don't have a solution to it. You don't have a solution to it. Together, we have to find a solution to it. So I'm kind of putting a little bit of onus or a lot of onus on the family member to solve this problem for me or for both of us. And then it forces them to think. I also say, if this goes on like that, if we are not able to match up to his expectation, he may say, no, take me somewhere else. Then what will we do? So, so every time you make a statement, this is the structure. You create a fact, you create a problem, and then you try to figure out how. And in trying to figure out how, you're saying, I don't know. Let us think of something, and that means you also think of something. So there is no trick to it. Frankly, I don't know how to solve this. I can, I'm just saying, how are we going to deal with it? So this way we gradually, it is not a trick, it is basically gradually you guide the family to a position where they see the merit in an open and transparent relationship with the patient. They know that increasingly they are getting into more and more complications by hiding and telling lies. And the only solution to that is being open and honest with information. Now, that is a skill, and that's what I'm saying. When you verbally say, it may make sense, but in the real ground situation, how do you implement it gets a little complicated, and a little bit of mentorship will go a long way in that. So that's where I stop. Probably unsatisfactory answer, but that's the best I can do verbally.
Dr. Nirali, she has some clarification.
So I have a question. As a physician, sometimes I feel a lot of anxiety when I have to disclose some bad news to the patient. Oftentimes I've seen that I fumble on words. So, sir, any tips for us physicians on how to not to be so anxious?
Okay. Now, again, I'm not a psychologist or a psychiatrist, just a regular doctor. So, so in case one is anxious by nature, that is any small trigger, anything and everything can trigger an anxious response within you. Perhaps finding out some, methods of taking care of that from a professional, maybe a clinical psychologist. They can teach people how to deal with it, stage fright, public speaking, etc., etc. And these are stressful situations. As doctors, communicating these things are stressful situations. So that itself may take care of a lot of the issue, including the fumbling part, because that comes with anxiety. The second part is, by and large, one is not that kind of a stressed out person, but extremely stressful situations like communicating bad news or dealing with anger, those kind of things. Now, for that, again, a very, very simple thing would be to indulge in role plays. In palliative care, we do indulge in role plays a lot. And it is not enough to do it as, once as part of your learning session. It is also great to go back to it and, let us have a role play session today as part of academics. Today, half an hour program, we are all going to do some role play. So basically, it is like doing a dress rehearsal for the big event. And even if you have done it a couple of times, the more you do, you just get better and better. You polish yourself. The first time I wanted to check BP for a patient, real patient, not in the lab, fumbled. The cuff fell off and all kind of things happened. No, any kind of skill is something that you get better at the more you practice. And specific words, for example, I mentioned about communicating what do you call, giving the warning shot. So it is also good to practice certain things that you say. It is also great to practice non-verbal communication, but when it comes to verbal part of it, the precision of it is important. So there are certain things that how are you going to say? It is good to practice. I'll give you an example. We as doctors are kind of uncomfortable with saying words like he is dying, right? So it is very important to practice it, because I remember, I think I was in Pallium India, I was working in Pallium India, Interventum, and there was a patient who was brought in by family members. A couple of gentlemen had brought a patient from another hospital. And me and my colleague, when we examined, we clearly saw that this person was gasping. And then we asked this, the people who brought him, what what do you think is happening? What did they tell you? They said that they told us that he is serious. Okay, fine. Then, like, I don't know whether it was me or my colleague, we said that, yeah, he's serious and he's also dying. And the people were taken aback, but nobody told us that. So basically, it is very important that when we use euphemism, that prognosis is not good, prognosis is guarded, these kind of words don't make any sense to people, because it does not penetrate as to what exactly we are trying to say. Just saying is serious does not convey what exactly we are saying. So spoken words to convey sometimes, or not sometimes, often it has to be very, very precise, and those precision can be uncomfortable. And the only way to get over the discomfort is to practice it. Sometimes doctors don't even say the word cancer. It is that disease. It's not a good disease. So those kind of words, I mean, don't beat around the bush. But when you are saying this, marshal all the empathy in you. That should come in your eyes, it should come in your face, it should come in the tone of your voice, it should come from your entire body. That is where mastering this body language is very, very important. You're saying it with precision, without any of your body language, it will cut somebody, like it will be so traumatic. Now that is where many times doctors say something, even if you're saying something clearly, then you're causing an emotional trauma. So how to say it clearly with minimizing emotional trauma, that is what active listening skills gives you. I hope that answers the question.
Yes, sir. Thank you so much.
Thank you so much, sir. Thank you all. I think we can wind up the session for the day.
So I wish all the participants the very best in your journey on improving our communication skills. And like you, I also started with listening to one session, and then then that journey started, and now now I'm teaching it. That's an unbelievable journey. So I hope that each one of you will get inspired and learn more and practice more and practice till you now start teaching other colleagues, and so that gradually we all healthcare professionals will have better quality of life. We'll be more happy working as doctors and safer working as doctors. So it is very important to improve our quality of life, our safety of life. And this is a good tool to achieve it. It is not a foolproof tool, but it is a good tool to achieve it. So I'll sign off with that. Thank you.
Thank you again, once again, sir. So this is Dr. Arjun, along with Anup, signing off from Pallium India. Good night all. Have a good evening.